Evening, everyone, and I would like to welcome you to our fourth installment of our Net Cells Medical Series. We are so excited that you are all joining us this evening. I do apologize for the slight delay. Unfortunately, we had some technical difficulties. Of course, it always happens as soon as we are wanting to present to you all. So thank you very much for your patience. Tonight we will be talking about cord blood in the use of treating multiple sclerosis, and this is going to be presented by our medical director, Dr. Yvonne Holt, and our scientific director, Professor Carola Niesler. And it was prepared by one of our medical technologists, Sacha Pillay, in our laboratory. So thank you very much, everyone, and I hope you enjoy the presentation. And I'm going to hand over to Yvonne.
Thank you, Shelley. Thank you, and good evening, everyone. Tonight's presentation will be on multiple sclerosis. I will go through the medical aspects of multiple sclerosis, just to put you in the picture, and then Professor Carola Niesler will discuss some potential stem cell treatments in multiple sclerosis. So to begin, Ellie, can you change the slides? Thank you. I would like to discuss what is multiple sclerosis, and it is basically a progressive autoimmune disease which causes demyelination of neurons in the central nervous system. Myelin is the protective sheath that surrounds the axons of neurons, allowing efficient transmission of electrical impulses, and is produced by cells called oligodendrocytes. Now, in MS, the immune system inappropriately attacks and destroys myelin and the oligodendrocytes, which does not allow electrical impulses to move between neurons. And this then leads to sensory, motor, and cognitive problems. MS is approximated to affect about 2.3 million people globally. So quite a significant disease in the human population. Next slide, please. Ellie, next slide, please. Oh, there we go. And now looking closely into the pathogenesis of the disease. So the brain and spinal cord are protected from substances in the blood by the blood-brain barrier, which only lets certain molecules and cells from the blood to pass through into the cerebrospinal space. Immune cells like T and B cells require the right ligand or surface molecule to get through the blood-brain barrier. In multiple sclerosis, there is a massive infiltration of autoreactive T cells, B cells, and antigen-presenting cells, including monocytes and macrophages. Once a T cell is through the blood-brain barrier, it can be activated by the unfamiliar environment of the CNS, where immune cells do not usually exist. In the case of multiple sclerosis, this is activated by myelin. Once activated, the T cells alters the blood-brain barrier cells, leading to the expression of more receptors, which allows other immune cells to easily bind and pass through the blood-brain barrier, flooding it with these immune cells. Next slide, please. So this flooding of the CNS by these immune cells is classified as a type 4 hypersensitivity reaction or cell-mediated hypersensitivity. So myelin-specific T cells release cytokines like your interleukin 1 and 6, tumor necrosis factor, and interferon gamma. And these cytokines dilate the blood vessels of the blood-brain barrier, allowing more immune cells to pass through. These cytokines also themselves damage myelin and oligodendrocytes. and they attract B cells and macrophages as part of the inflammatory reaction. The B cells then make antibodies which mark the myelin sheath proteins, and the macrophages use these antibody markers to engulf and destroy the myelin and oligodendrocytes, leaving scar tissue behind called plaques or sclera. Overall, these clusters of immune cells in a portion of the brain causes a neuroinflammation. The immune-mediated attacks occur in bouts, whereby the autoimmune system attacks the oligodendrocytes and is then followed by a reduction in inflammation by regulatory T cells. So you get these attacks when you get these inflammatory reactions, and then your regulatory T cells reduce the inflammation and the attack subsides. So in the early phases of multiple sclerosis, oligodendrocytes manage to heal and extend out new myelin to cover the neurons, a process called remyelination. Unfortunately, over time, as oligodendrocytes are destroyed and overwhelmed by the power of the autoimmune response, the remyelination stops and the damage becomes irreversible with the loss of axons. And next slide, please. So the etiology of MS is generally unknown. It isn't clear why MS develops in some people and not others. So much research has shown that it is possibly a combination of genetic and environmental factors that appear to increase the risk of developing MS, and more specifically, those are like the sex of the patient. Usually, women are more than 2 to 3 times more likely than men to have the relapsing remitting type of MS. Some genetic mutations have been identified, those that encode for the HLA-DRB1, which is used to identify and bind foreign molecules. Certain infections, a variety of viruses have been implicated in MS, and then vitamin D deficiency. Your low levels of vitamin D and low exposure to sunlight is also associated with a greater risk of MS. Next slide, please. So there are 4 types. Next slide, please. There are 4 types of MS that are described based on a pattern of symptoms over time. So the first type is and the most common type is your relapsing remitting MS. And this is seen in 4 out of every 5 patients with MS. It is characterized by alternating periods of autoimmune attacks, which occur months or years apart and full recovery in between. In relapsing remitting MS, there is an increase in level of disability due to incomplete remyelination, which results in residual disability that remains. There is no increase in disability between bouts. The next slide, please. Second type of MS is your secondary progressive MS, which is characterized by initially by similar symptoms to your relapsing remitting MS, but over time the autoimmune attacks become more frequent and more constant, and this leads to then a steady progression of disability. Next slide, please. The third type is your primary progressive MS, which is characterized by constant autoimmune attacks on myelin, and this leads to a steady progression of MS in a person's life. And then next slide, please. The fourth type is your progressive relapsing MS, which is also constant attacks with bouts superimposed, which results in disability happening even faster. These patients have the shortest lifespan. Next slide, please. Now, the signs and symptoms, I mean, how do we recognize MS in patients? And generally, it typically affects people between the ages of 20 and 40 years old. Symptoms obviously vary from person to person depending on the location of the plaques in the CNS. And symptoms related to bouts worsen over weeks and can even linger for months without treatment. The three most common symptoms are described in something that we call Charcot's neurologic triad, and those symptoms are dysarthria, nystagmus, and intention tremor. The dysarthria is a motor speech disorder in which the muscles used to produce speech are damaged, paralyzed, or weakened. It is as a result of plaques in the brainstem that affect nerve fibers which control the muscles in the mouth and throat. And this can interfere with conscious movements, such as eating and speaking, and unconscious movements, such as swallowing. Then your nystagmus, which is your involuntary eye movements, this occurs due to plaques affecting your optic nerve and your nerves controlling eye movement. Then intention tremor, this is due to plaques along the motor pathway in the spinal cord, which can affect outbound signals like skeletal muscle control. Next slide, please. Additional signs and symptoms that occur are caused by plaques in your sensory pathways, which can affect inbound signals like sensations from the skin, which can cause numbness and pins and needles. Plaques in the autonomic nervous system, which can lead to bowel and bladder symptoms, as well as sexual dysfunction. MS can also affect higher order activities of the brain, which can cause poor concentration and critical thinking, as well as depression and anxiety. Apologies, I see there is a mistake on the slide. It says, as well as expression, it should be depression and anxiety. Next slide, please. The diagnosis of MS really is suspected when there are several neurological symptoms that are generally spread over space and time. Space being different locations in the nervous system, and time separate bouts followed by remission. And diagnosis is made by MRI imaging, where we see plaques. On the MRI, the little red arrow is pointing to a plaque. We do spinal taps or lumbar punctures, and the cerebrospinal fluid contains high levels of antibodies. And then we also do visual evoked potential, which measures the nervous system's response to visual stimuli. Next slide, please. So moving on to treatment of MS once we've diagnosed it, unfortunately there is no cure for multiple sclerosis. Treatments can help by speeding up recovery from attacks. Things like corticosteroids are used for that, to modify the course of the disease, and there are several disease-modifying drugs, as well as managing specific symptoms. So treatments are particularly effective for relapse-remitting MS, since they lessen the severity and occurrence of relapses. But there are fewer treatment options that are available for more progressive multiple sclerosis. Treatments like physical therapy and cognitive rehabilitation therapy just really target to managing the symptoms. So now I shall hand over to Professor Carola Niesler, who will discuss potential stem cell treatments for this disease for which we have no cure. Thank you, Carola.
Thanks, Yvonne. So in the next 15 minutes or so, I'm going to just discuss some clinical trials which investigate whether stem cells can in fact improve disease outcome in patients with multiple sclerosis. Next slide, please. And the first study is entitled High-Dose Immunosuppressive Therapy and Autologous Haematopoietic Cell Transplantation for Relapsing Remitting MS. So it's the RRMS form of multiple sclerosis. This is a 5-year study which hypothesized that high-dose immunosuppressive therapy followed by autologous hematopoietic cell transplantation would remove disease-causing cells and induce a reset of the immune system and sustained remission of the relapsing remitting multiple sclerosis, thereby controlling the disease. Next slide, please. So the selection criteria are shown here. Participants were between the ages of 18 and 60 years old and had relapsing remitting multiple sclerosis for less than 15 years. According to the McDonald criteria, the lesions seen on brain MRIs were consistent with multiple sclerosis. And on the expanded disability status scale, patients had a score of between 3 to 5.5. Now, this indicates a disability that ranges from moderate to that which affects all aspects of daily life. Furthermore, a failure of disease-modifying therapy was included in the selection criteria, and this was defined as 2 or more clinical relapses over 18 months while on therapy, and a sustained EDSS increase for 4 weeks or longer. 24 patients were recruited to the study, of which 17 were female and 8 were male. Median age was 37 years with a disease duration of 4.9 years and a baseline EDSS shown by the red arrow of 4.5. And participants had previously failed 3 non-transplant multiple sclerosis medication interventions. Next slide, please. During the procedure, doctors collected the participants' hematopoietic stem cells from the peripheral blood. And then they gave the participant high-dose chemotherapy to deplete the immune system, as well as rabid anti-thymocyte globulin. The patient's own stem cells were then reinfused to rebuild the immune system. And then 5 days later, filgrastim was administered. This is a medication used to treat low neutrophil counts. A few days later, prednisone was administered. This is a glucocorticoid medication used to suppress the immune system and decrease inflammation. In this case, it was used to prevent engraftment syndrome. Now, engraftment syndrome is a clinical condition that is characterized by fever, pulmonary edema, liver and renal dysfunction, and other symptoms. And it occurs at the time of neutrophil recovery after hematopoietic stem cell transplantation. Next slide, please. The primary endpoint was event-free survival, and this was defined as survival without either death or disease activity, and this is up to 5 years post-transplant, from either disability progression. So this would be measured as a greater than a 0.5 point change on the EDSS scale, relapse, and this was measured as a relapse lasting more than at least 48 hours. Or new lesions as detected by MRI, and that would be 2 or more new lesions. The table that is shown here summarizes all these primary endpoints and subsequent events, which we're going to touch on in the next few slides. Next slide, please. So unfortunately, 3 participants, and these are the participants highlighted in red, experienced disease progression and died. The final cause of death was cardiopulmonary arrest, and patients with multiple sclerosis are known to have a 5-fold higher incidence of sudden cardiac arrest. None of the deaths were deemed to be related to the study treatment. So what you can see on this particular slide is the highlighted patients that died during the trial, and they are highlighted in the red. And then the remaining 21 patients, you can see their subject IDs on the left, and along the bottom axis you can see prior to transplant, and then time 0, which is when the transplant occurred, and then subsequent follow-up. Next slide, please. So looking at the same schematic, of the remaining 21 patients, 2 did not actually maintain event-free survival due to clinical relapse. And this is again shown in red, patient and subject ID 8 and 19. However, the relapse activity was actually reduced post-transplant as compared to pre-transplant for all participants. And you can see that because prior to the transplantation, on the left of the line at 0, the incidences of relapse, which are shown by these blue stars, is a lot more than the relapses that are occurring to the right of that line at time 0. So, so this was something very positive. Next slide, please. When we look at the expanded disability status scale, the EDSS score, participants who survived and completed the study showed an overall 0.5 point decrease from baseline at 5 years. So on the graph, you can see at month 6 and then following through to year 5, there's a gradual decrease in the score. And so you want that score to be lower, and that shows an improvement. So in other words, that would have shown overall improvement. To expand a little bit, the EDSS score quantifies disability in multiple sclerosis patients and helps to monitor changes in disability over time. So the higher the score, the higher the disability. And in this particular trial, they found that the changes from baseline pre-transplant were 15 patients displayed an improvement, 5 patients remained stable, and 4 progressed. In other words, they became worse in terms of their symptoms. Next slide, please. If we take a look at the multiple sclerosis functional composite score, now this score is in 3 parts. This showed an improvement from baseline after 1 year, and this improvement persisted through 3 years post-transplant. So you can see there's an increase in this value from month 6 through to year 3. However, subsequent to that, there was a decrease in the value, and so this improvement wasn't actually sustained by 5 years post-transplant. So just to qualify, the multiple sclerosis functional composite is a component is a measure which includes measurements from the 3-second paced auditory serial addition test, the 9-hole peg test, and the time 25 foot walk test. Next slide, please. If we move on to the MRI studies, 2 participants failed to maintain the event-free survival post-transplant, and this was due to the development of new brain gadolinium-enhancing lesions, or T2 lesions. So the GD lesions are shown in the left in A, and the T2 lesions in B on the right. So on the left, the GD positive lesions are seen at year 3 and 4. Yeah, and these are actually 2 different lesions observed in the same participant. Whereas on the right, I'm showing the new T2 lesions seen at year 4. This is actually in 1 participant, so in a single individual. Next slide, please. So from this study, the summary and conclusion was that after 5 years of receiving treatment, 69% of trial participants had survived without experiencing progression of disability, relapse of multiple sclerosis symptoms, or new brain lesions. Some participants showed improvements, such as recovery of mobility or other physical capabilities, which was very favorable. So this compares favorable to results from non-transplant studies that enrolled participants with less severe multiple sclerosis. And in conclusion, high-dose immunosuppressive therapy and autologous haematopoietic stem cell transplantation without maintenance therapy was effective for inducing long-term sustained remission of active relapsing remitting multiple sclerosis at 5 years. Next slide, please. So due to the encouraging results of this study, the development of a large randomized trial to directly compare high-dose immunosuppressive therapy and autologous hematopoietic stem cell transplants to current standard of care is needed. So one such study is the BEAT-MS trial that is currently enrolling participants. If findings are confirmed in larger studies, then the treatment may become a potential therapeutic option for patients with active relapsing remitting multiple sclerosis who do not respond to conventional immunotherapy. Next slide, please. So in the next study, we're going to switch gears a little, and we're going to look at a study entitled Clinical Feasibility of Umbilical Cord Tissue-Derived Mesenchymal Stem Cells in the Treatment of Multiple Sclerosis. So here we're looking at mesenchymal stem cells rather than the haematopoietic. So several clinical trials have found that mesenchymal stem cell therapy can be effective in treating neural damage in patients with multiple sclerosis. And so the current study was a safety and feasibility study on the use of allogenic umbilical cord mesenchymal stem cells as a treatment for multiple sclerosis. Next slide, please. Again, we have the selection criteria, ages 18 to 55 years, the multiple sclerosis identified according to the McDonald criteria, and the expanded disability status scale showing patients with a range of 2 to 7, which indicates minimal disability on the left, ranging up to essentially restricted to wheelchair. The enrolled subjects were not required to stop taking other medication or supplements prior to the study. And in this case, 20 patients were enrolled, again, more females than males, so 12 females and 8 males with a mean age of 41 years. In this case, we had a mixture of different types of multiple sclerosis, so the majority being the relapsing remitting multiple sclerosis, 15 patients, and then 4 patients with primary progressive multiple sclerosis and 1 with secondary progressive multiple sclerosis. The baseline EDSS was 5, as shown by the red arrow, and the mean disease duration was 7.7 years. Next slide, please. So in this 1-year study, consenting subjects received 7 intravenous infusions of umbilical cord mesenchymal stem cells. And these mesenchymal stem cells were obtained from donated tissues that were taken from the cord after full-term healthy births. And basically, if you read the paper, the mesenchymal stem cells were isolated by a standard collagenase digestion and within passage for 5 passages prior to preparation for infusion. At each treatment, the subjects were checked for adverse events experienced since their last visit and also reviewed for adverse events throughout the visit. And finally, the efficacy parameters were checked then at baseline, 1 month, and at 1 year post-transplantation. Next slide, please. So the study, also in the study, all subjects survived. And there were actually very few, there were no serious adverse events and very few moderate adverse events and 66 mild adverse events. So your mild adverse events ranging from headaches and fatigue to dizziness and some musculoskeletal effects. However, none of the reported adverse events required any kind of adjustment or interruption or discontinuation of the treatments. Next slide, please. So if we look at the expanded disability status scale shown here, then what you see is the recorded scores at baseline and 1 month post-treatment for all subjects are 5.2 or 5.23, then decreasing down to 4.75. So there's a decrease from baseline to 1 month and a further decrease down to 1 year to 4.62. And these effects were significant, and that was significant from baseline to 1 month and baseline to 1 year. Next slide, please. So if we move on to the Scripps Neurological Rating Scale, a significant improvement was seen for bladder, bowel, and sex dysfunction categories. particularly at the 1 month time point, where we had an improvement from a -4.7 to -2.65. However, this dipped slightly at 1 year to a -3.12, while still remaining improved over baseline, which was a positive effect. Next slide, please. And moving on to the MRI, pre and post treatment MRIs from the brain and the cervical spinal cord were reviewed qualitatively for every subject. And the 18 subjects that were analyzed or that completed MRIs both at baseline and at the 1 year follow-up, of these, 15 subjects showed no disease progression or no new or active lesions, which was very positive. 2 subjects showed progression in their lesions, 2 out of the 18, and 1 subject, which is the subject shown here, actually showed near complete resolution of the plaques in the brain, where areas of abnormal signal intensity consistent with demyelinating disease were seen before. So you can see the plaques shown with a white arrow prior, and then subsequently they are not seen on the MRI. So that's incredibly encouraging. So this is particularly encouraging, finding that you should actually be further investigated by comparing it to similar multiple sclerosis cohorts in a standardized time period. Next slide, please. So to conclude, treatment with umbilical cord mesenchymal stem cells, and these have been cultured for a number of passages in vitro prior to infusion. So treatment with these mesenchymal stem cell infusions for subjects with multiple sclerosis is safe and has the potential therapeutic benefit that it can actually improve a number of the aspects of multiple sclerosis. And so this application should be further investigated. The most significant limitation of the study is the small sample size, and as this might impact the statistical significance, and so further trials should increase this or should focus on this. Next slide, please. Right, so again, changing track a little bit and moving a little bit away from multiple sclerosis. As we approach World Autism Day, we're reminded of some parallels perhaps between autism and multiple sclerosis, namely the effect on the myelin sheath. So in this particular study, the myelin-related transcriptomic profile is shared by Pitt-Hopkins syndrome models and human autism spectrum disorder. And this study, they initially aimed at studying brain cells in mice with a gene mutation that causes this Pitt-Hopkins syndrome, which is incidentally an autism-related genetic disorder. Next slide, please. However, the unintentional finding of the study was that both mouse and human brains affected by autism show an abnormality in oligodendrocytes. So more specifically, there's quite a noticeable lack of these mature oligodendrocytes, so the OLs on this excerpt, and an overabundance of the immature cells, which would be the OPCs, the oligodendrocyte progenitor cells. And myelination is not happening sufficiently in the brains affected by autism when compared to the controls. The results of the study and similarities with multiple sclerosis in both myelination and how those affected show wide ranges of disabilities could explain the spectrum of social and behavioral impacts on those with autism. And if this is found to be true, then there's a possibility that symptoms of autism could actually potentially be prevented or even reversed, where early intervention could change the developmental trajectory of children with autism. And this is based, and of course, on the knowledge that most rapid and dramatic period of human central myelination occurs within the first 2 years of postnatal life, which is around the time that autism is first apparent. And there are a number of trials that are ongoing to actually investigate this, and hopefully in the near future we'll see some successful results. Right, so that takes me to the end of this part of the presentation. I'd say thank you very much for your time, and we'll take any questions.
Thank you so much, Carola and Yvonne, for your presentation. I hope that everyone found it informative. And as Carola has said, please, if you've got any questions, do send them through to us now. I do have one question already, which I'll either direct to, it can go to Carola or Yvonne. And the question is it known why women are more likely to develop MS than men are? Not too sure who would like to answer that one.
So Yvonne, do you want to take that? Or?
Yes, I can certainly give it a try. So what is postulated, and this is actually information that Carola found, is that so the blood-brain barrier, there is proteins obviously control the permeability of the blood-brain barrier, and these proteins are more prevalent in people with MS. So analysis of humans that had MS, they've seen that women seem to produce more of this protein than men, making the blood-brain barrier more permeable, and thus it is, allowing the immune cells to cross the blood-brain barrier and cause issues with the myelin and oligodendrocytes.
Fantastic. Thank you so much, Yvonne. I don't see the questions coming through, so maybe you've actually answered all potential questions that our audience may have had. If anyone does have any questions following the presentation, please don't hesitate to reach out to us. We're always happy to answer any questions you may have. But as there are no questions, I think we will be finishing off for the evening. So I just want to thank everybody so much for dialing in. It has been it's been wonderful having you here. And as Carola alluded to, we did hold this webinar in honor of Autism Awareness Day, which is tomorrow. So we hope that you all have a wonderful evening and stay safe over Easter. And thank you again to Yvonne and Carola for hosting this medical series. So thank you very much, everyone, and goodbye.
Thanks, everyone. Have a good evening.
Thank you. Bye-bye.